Right, just before the break, we were starting a conversation with Dr. Aaron Motsoaledi, the Health Minister, who's in our Pretoria studios because his white paper on the NHI is going to be gazetted tomorrow and Friday. Let's go back to Pretoria now and continue our conversation. Thanks for staying with us, Dr. Motsoaledi. The first question that I have is, why did we have to introduce or try to introduce the NHI in South Africa?
Well, it's a system of universal health coverage, Peter, because maybe let me define it so that you understand why we had to have it. NHI is a healthcare financing system designed to pool funds to afford access to good quality healthcare services for all South Africans in terms of their health needs, regardless of their socio-economic status. That is the definition, Peter. Now, that definition is exactly what medical aids are doing, except that there are two very notable differences, which makes medical aids and NHI look like a chalk and cheese, if I may say. The first notable difference is the word all. We are saying we are pooling funds for all South Africans, whereas in medical aids, we are pooling funds for a selected few, the cream of the crop, usually those people who have got some form of income, not only income, but some decent income. Now in NHI, we say all South Africans because it's universal health coverage. The second notable difference is the word regardless of your socio-economic status. Remember, in medical aid scheme, even though you belong to the same scheme, but you are still stratified according to your income. If you are employed at the higher level, you earn more money, you have got a bigger subsidy, and you have got a bigger package, a better package for healthcare. If you are employed at the lower level, you earn a lower salary, and you get a lower subsidy, and you get a lower package of healthcare. Now, all those things are problematic, Peter, because, as you know, high blood pressure is high blood pressure. How do I treat Peter Ndoro with high blood pressure, with a particular regime of medication? Then the person you are working with, maybe you are a receptionist. We say, no, look, because you are at the level of receptionist, you also have high blood pressure, but we can't give you the good quality drugs. We give you a lower treatment at your level. That is just against the Constitution. It's against morality. It's against the Hippocratic Oath. It's against all the laws of humanity that are decent. And we can no longer continue with that type of system. That's why we need NHI.
All right. So, Minister, who's going to pay for it? Does every single working person contribute? And if so, is this not another tax?
Well, Peter, just like we are on medical aid, every South African who can will definitely contribute. As to in what form, Treasury will decide. I won't decide that. And then the South Africans, after all, that's what they are doing. Every South African who's on medical aid contributes something. But the difference is that South Africans who cannot contribute, the state must find a way to contribute them. Exactly in the same way as President Obama tried to do in America, which unfortunately President Trump is now reversing. What we call Obamacare is a universal health coverage for United States because Americans, most of them, have got private health insurance. But President Obama noted that 20 million Americans, and mostly these are poor black Americans, 20 million of them could not afford that system, and President Barack Obama found a way through which the state, within its resources, can bring them into such a system. That's basically what we'll be doing in South Africa.
So, Minister, you launched some pilot projects, phase 1, and it seems that these pilot projects haven't worked very well. So this doesn't bode well for the full implementation of NHI. How do we jump from what we've seen with the pilot projects to a full-on system if the pilot projects have been problematic?
Well, Peter, I don't know. There is a misunderstanding of what the pilot projects was about. The pilot projects were not NHI. We just called them NHI pilot districts. But what we're doing was to massively reorganize the healthcare system and see what it should look like in order for it to be appropriate to NHI. We were massively reorganizing and learning how the healthcare system can be reorganized, how the problems will be there. The reorganizing consisting of trying to see what type of human resources can you bring. Can you bring, for instance, GP? We also brought in a team of 7 specialists in each of the districts. Can we do school health, whereby the 12 million kids going to school every day are taken care of? And in that regard, we have screened 3.2 million school kids for physical barriers to learning, which are eyesight, hearing, oral hygiene, and speech. And guess what? We discovered that 500,000 kids have one of these problems that I've just mentioned. They need help. If without that help, they are going to school will be useless. Now, that's a very, very important thing, which we have done there. We also put up the what we call robots teams, the ward-based primary healthcare teams that have visited families to check whether people have got diabetes, high blood pressure. As I'm speaking now, 4 million people, families, 4 million households have already been visited by these teams. We know that in that family, somebody has got high blood pressure, somebody has got diabetes, somebody is HIV positive, there's a girl there with teenage pregnancy, etc., etc. So those are some of the things that we did, but we also piloted the issue of infrastructure. We have already spent 40 billion rands on the issue of renovation of infrastructure, putting up new infrastructure, putting up doctors' consulting rooms. So that's what we call piloting NHI. It means we were looking at how the healthcare system can be massively reorganized.
All right, but you have said that for that to happen, there needs to be a radical overhaul, and that is going to touch various areas. Explain to us the kinds of things that are going to need to be restructured.
Well, we are going to restructure both in the public and private healthcare. The structure of that healthcare system, the structural anomalies need to be taken care of. In the private healthcare, Peter, whereas many people believe the system is very efficient and of good quality, the fact remains is extremely exorbitant. The costs are just out of this world. In fact, even the World Health Organization and the Organization for Economic Cooperation and Development, or OECD, they've actually concluded and presented this evidence to former Judge President Ngobo, former Chief Justice Ngobo, who was doing inquiry into the cost of private health care. They presented to him that actually the present private health care system in South Africa is so expensive that only 10% of the population can afford it. Previously, we were thinking that is 16% of the population who can afford it, meaning the 16% who are on medical aid. Their finding says no. Even part of the population on medical aid are finding it very difficult to keep up with this system. They run out of benefits early on in life and have to go back to the to the public healthcare sector. So that needs a lot of restructuring and rearrangement. In the public healthcare system, the restructuring, the massive restructuring will consist mostly of putting back quality and efficiency. That means looking at human resources, looking at procurement systems, looking at maintenance of the infrastructure and equipment, looking at the issues of the long queues that people now have to endure when they go to the public healthcare system, looking at the filing system, how to modernize it and computerize it,
I think
and maybe even
now,
eventually have
Dr.
paperless filing.
Thank you very, very much indeed. Unfortunately, we've run out of time. There's still so much to talk about, but hopefully we can have this conversation a little bit more.
Indeed.
Thank you very much for your time. That was Dr. Aaron Motsoaledi, the Health Minister, talking to us about the NHI White Paper, which is going to be gazetted tomorrow.